The first few hours of a preterm infant's life are extremely critical to establishing feeding and provide the right nutrition. A preterm infant may exhibit feeding difficulties, since the suck-swallow coordination only starts at 34 weeks gestation. As discussed in the previous session, it is important to establish enteral feeding in preterm infants as soon as possible, using the mother's colostrum and milk as the first choice. It is also important to provide support to mothers for successful initiation and continuation of breastfeeding soon after birth. The use of breast milk for enteral feeds leads to less gastric residuals and faster achievement of full enteral feeds. Faster achievement of full enteral feeds would mean fewer days of parenteral nutrition, fewer side effects associated with total parenteral nutrition, and reduced hospital days and hospital-associated costs. Today, we will discuss the benefits of breastfeeding and feeding human milk to preterm infants, the challenges of providing human milk to premature infants, and the use of pasteurized donor human milk as a breast milk alternative. Breast milk is considered the best source of nutrition for all infants, including preterm infants. The American Academy of Pediatrics and the European Society for Pediatric Gastroenterology, Hepatology and Nutrition Committee recommend that mother's own milk should be the primary choice of diet in preterm infants. The World Health Organization states that all infants, including small, sick, and/or preterm infants, should be fed breast milk in the first 6 months of life. Soon after the infant is born, it is important to facilitate immediate skin-to-skin contact or kangaroo care with the mother to provide stable warmth and to encourage frequent and exclusive breastfeeding. It is also important to provide support to mothers for successful initiation and continuation of breastfeeding. Every effort should be made to feed breast milk to preterm infants as early as possible, since breast milk not only reduces neonatal morbidity and mortality, but also helps support preterm growth, development, and enhances overall outcomes. Let us look at each of the benefits of breast milk in preterm infants in detail. The bioactive substances present in the breast milk possesses bactericidal, immune-modulating, and intestinal maturation-inducing properties that helps in reducing the complications associated with preterm birth and improve health, especially those in infants who are born extremely premature. Additionally, breast milk has antioxidant properties that assist the preterm infant in coping with the increased oxidative stress soon after birth. Breast milk has also been found to reduce the occurrence of feeding intolerance, sepsis, and retinopathy of immaturity. Retinopathy of immaturity is a condition caused by abnormal development of retinal blood vessels in the eyes of preterm infants that may cause visual loss. Increasing evidence suggests the role of breast milk in the improvement of gastrointestinal function in preterm infants. Breast milk improves gastrointestinal function via decreased gastric pH, increased gastrointestinal motility, better mucosal immunity, improved gut microflora, and decreased mucosal permeability, which translates into reduced bacterial entry. Furthermore, the enzymes present in breast milk help immature infants absorb and utilize nutrients more efficiently. Research suggests that breast milk offers strong protection against infections and a condition known as necrotizing enterocolitis, or NEC. Necrotizing enterocolitis is an acute inflammatory bowel disease, which may lead to perforation of the intestine and inflammation of the peritoneum, the tissue that lines the inner wall of the abdomen. Necrotizing enterocolitis can occur due to intestinal mucosal injury, inflammation, and the presence of abnormal intestinal colonization. Breast milk reduces the incidence and severity of NEC through its bactericidal, immunologic, antioxidant, and anti-inflammatory properties. The protection of breast milk against NEC appears to be dose-dependent, with consumption of more than 50% of the total feeds providing the greatest protection. In the long term, breast milk also protects preterm infants from developing obesity, blood pressure, and insulin resistance during adolescence. Furthermore, breastfeeding in preterm infants has been found to be associated with better cognition in adolescence. The key components that are thought to mediate improved cognitive outcomes include long-chain polyunsaturated fatty acids and human milk oligosaccharides present in the breast milk. Considering the several benefits offered by human milk in breastfeeding, it is important to provide support to mothers for successful initiation and continuation of breastfeeding soon after birth. Before initiating breastfeeding, it is also important to assess the infant's abilities and readiness to feed. The infant should be clinically stable, should be able to coordinate breathing, sucking, and swallowing, should be able to suckle with very rare episodes of apnea and bradycardia, and should be alert and ready to attach. Infants who are about 34 to 35 weeks gestational age generally have good sucking reflex and suck-swallow-breathe coordination, and may be able to suckle on the breast directly. Mothers should receive support from the nursing staff for correct positioning of the infant, proper latch, milk flow, and safety of the infant. Correct attachment may be difficult for small, sick, and preterm infants, and should be taught and observed frequently until both the mother and the infant are comfortable with the latch. Non-nutritive sucking via sucking of a clean finger or pacifier is recommended in preterm infants when the mother is not available for skin-to-skin care or breastfeeding. Non-nutritive sucking has pain-relieving and stress-relieving effects in preterm infants. When pacifiers are used for non-nutritive sucking, it is important to keep them hygienic to avoid infections. If preterm infants are not able to breastfeed immediately after birth, they may require extra support for feeding with nasogastric feeding tubes or other devices. This also depends on the gestational age of the preterm infants. Preterm infants born between 28 and 32 weeks of gestational age may lack suck-swallow-breathe coordination and may need to be fed by a nasogastric tube. The method of tube feeding has been discussed in the previous session. An alternative feeding method such as a cup, beaked cup, spoon, dropper, or a syringe can be used, either short-term or long-term, before transitioning the infant from tube feeding to breastfeeding. Cups or beaked cups are easier to use and clean, easier to teach the mothers on its usage, are inexpensive, with better breastfeeding outcomes compared to bottles. Spoons, dropper, or syringes can be used to collect and feed colostrum and are meant for short-term use. Syringes and droppers can be used alone or to supplement breastfeeding by placing at the corner of the mouth. Here's how nurses can encourage mothers to feed the infant using a cup, beaked cup, or a spoon. The infant should be wrapped securely with a drip cloth under their chin and held in a semi-upright position. The cup should be slightly tipped so that the milk is just reaching the infant's lips with the cup resting gently on the infant's lower lip. Generally, the infant smells the milk and sips or laps the milk with his tongue. The cup should be in place while the infant swallows or rests, allowing him or her to regulate his own intake. Advise the mother not to pour the milk into the infant's mouth. The nurses should observe the mother practice feeding her infant with a cup at least 2 to 3 times before feeding her infant with a cup on her own. To facilitate feeding the breast milk through alternative methods, mothers should be encouraged to express their breast milk soon after delivery. The mother should receive verbal and written instructions on the pumping and storage of breast milk. The Week 6 session entitled Counseling Mothers on Right Breastfeeding Practices provides detailed information regarding the pumping and storage of breast milk. Please go through the module to refresh your memory on the pumping and storage of breast milk. If the mother's own milk is insufficient, unavailable, or contraindicated, the American Academy of Pediatrics and the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition Committee on Nutrition, and the World Health Organization recommend the use of donor human milk as the feed of choice. Although donor human milk may not be as suitable as the mother's own milk, it can act as a bridge until the mother's own milk is available and sufficient. Providing donor human milk to vulnerable preterm newborn infants who do not have access to mother's own milk can save lives and increase awareness on the value of breastfeeding and human milk. Despite several benefits offered by human milk and breastfeeding, it is important to note that there are several challenges associated with the use of human milk for preterm infants. These challenges include availability of the mother's own milk, sustainability of milk expression when infants are not feeding on the breast, effect of pasteurization on the nutritional and immunological content of donor milk, transmission of viruses, including human immunodeficiency virus through the use of donor milk. Unfortified human milk does not meet the high nutritional requirements of preterm infants, leading to inadequate postnatal growth. The nutrient requirements, especially protein and energy requirements per kilogram, are higher in preterm infants compared to term infants. The protein requirements in preterm infants, as per the European Society of Pediatric Gastroenterology, Hepatology and Nutrition, are 4 to 4.5 grams per kilograms per day for infants weighing up to 1,000 grams, and 3.5 to 4.0 grams per kilograms per day for infants weighing 1,000 to 1,800 grams. Recommended energy intake for healthy growing preterm infants with adequate protein intake is 110 to 135 kilocalorie per kilogram per day. This may be also due to difference in the composition of breast milk of preterm mothers and the milk of mothers of term infants. This is true for donor milk too, since human milk donors may be mothers of healthy term infants, and the milk may be significantly different from the milk of a mother who has just delivered, especially if she delivers prematurely. Furthermore, there may be a decrease or loss of nutrients and other important milk factors with processing, storage, and feeding. Let us look at the key differences between preterm milk and term milk. Preterm milk contains higher levels of energy, protein, fat, and sodium during the first 2 weeks of lactation. The protein content in preterm milk is especially higher than in term milk during the first few days of lactation, which decreases later to reach same levels as term milk by 5th or 6th week. The lactose, calcium, and phosphorus content in preterm milk may be slightly lower compared to term milk. It is important to note that the nutrients present in preterm milk are insufficient to meet the needs of the preterm infant, with the deficits ranging from small to very large. These deficits are particularly high for protein, calcium, phosphorus, and zinc. Thus, even after full feeds are established, nutrient gap formed by the consumption of preterm milk needs to be filled by human milk fortification. Human milk fortification is the addition of protein and minerals to human milk, so that the composition of human milk is close to the nutrient levels required for rapid growth and bone mineralization of the preterm infant. We will learn more about human milk fortification in the upcoming session. Thus, the importance of breast milk and its role in improving the survival and health of preterm infants is universally recognized. Nurses play an important role in providing timely and appropriate care for mothers and infants in the neonatal ward. The nurses should have adequate knowledge and skills needed to provide appropriate care for the feeding of preterm and low birth weight infants. The Baby Friendly Hospital Initiative, a joint effort led by UNICEF and the WHO, has undertaken several efforts for the care of small, sick, and/or preterm infants. The aim of the BHFI is to aid staff, units, hospitals, and systems caring for small, sick, and/or preterm infants in their efforts to promote, support, and protect breastfeeding in order to achieve the best possible outcomes for infants, mothers, and families. Implementation of these initiatives in hospital facilities can substantially improve the health and well-being of both mothers and infants globally.